My name is Anna Cleveland. I'm a Regents professor and the director of the Health Informatics Program for the Department of Information Science at the College of Information, UNT. So we are delighted to have Dr. Halamka this evening, and he has been a leader and a visionary in healthcare technology. He's the president of the Mayo Clinic Platform and enterprise co-leader platform and digital innovation at Mayo Clinic Comprehensive Cancer Center. He's a professor in the Department of Emergency Medicine, and he holds a joint appointment in the Department of Internal Medicine. As president of the Mayo Clinic Platform, Dr. Halamka is responsible for global digital businesses, including virtual care for patients with severe illnesses, big data analytics, and unique infrastructure that brings telemetric together with AI algorithms to enhance access to specialty care. Dr. Halamka's research and clinical background combined with his passion, he has a passion for teaching, and this is a perfect example tonight of reaching out to our students and our university, have enabled him to implement innovating technologies at the local, regional, national, and international level. He had written many books and publications, and he was elected to the National Academy of Medicine in 2020. One of the things that I have been impressed with Dr. Halamka, it is that he and his wife run the Unity Farm Sanctuary in Shelburne, Massachusetts, dedicated to the lifetime care of ill, disabled, senior, orphaned, and surrounded farm animals. The title of his presentation tonight is Developing and Deploying Large Language Models in Healthcare. So let's welcome Dr. Halamka. Dr. Halamka, thank you so much for being so generous with your time and sharing your expertise with us at UNT.
Well, I'm just thrilled to be here. And what a wonderful time it is for all of us. I have been working on AI for 40 years. And in a sense, large language models are an overnight revolution in AI that's been 40 or 50 years in the making. And the journey has gone something like this. We know that whether it's predictive or generative AI, it's ultimately math, not magic. And that math depends on large amounts of curated data. So if you think about this journey over the last several decades, one problem we've had is that the data that we collect about our patients has not been what I'll call liquid. It's not been able to be used and leveraged to create novel innovation. So a prerequisite is really organizing the nation's data and, in fact, organizing the world's data. So as we lead up to large language models and other kinds of foundation models, I want to tell you a little bit about the journey of organizing the world's data. At Mayo Clinic, we have about 10 million patients, and those 10 million patients' birth-to-death records, about 50 petabytes of information, are structured, unstructured images, telemetry, digital pathology, and genomics. Now, you're informatics folks, so you know that if we take the structured data, problem lists, medication lists, allergy lists, and labs, to use those to create AI really requires first de-identifying them, because we certainly wouldn't want to use patient-identified information to create a model. And de-identifying structured data is not so hard. You just agree on the standard format you're going to put it in, and you're going to agree on vocabularies you're going to use, like SNOMED, LOINC, and RxNorm. You remove the 18 HIPAA identifiers, name, address, phone number, and that kind of thing. And then you have a nice de-identified data set that can be used for model creation. But I would argue 80% of the wisdom is not in the structured data in our medical records. It's in the unstructured text. It is in the journeys that are described, the signs, the symptoms, the patient progress, the patient outcome. So here's a challenge for you all, and you've probably studied this. How do you de-identify structured unstructured text so that it could be used for AI, predictive and generative. Well, the challenge is the following. So suppose, and I'll make this up, although we've removed all the names, addresses, and phone numbers from a note, if the imagine the first line of the note is, and this educational leader who has led the informatics program in Texas. Now, of course, I didn't mention a name. And of course, there could be multiple informatics leaders in Texas, but chances are it's a pretty small number. And therefore, it's not really de-identified, is it? And in speaking with colleagues in the Food and Drug Administration, Office of Civil Rights, and other health and human services agencies, the US government, they would say that if you try to create a generative AI model that is based on, say, not fully de-identified data, that's probably a privacy violation, a HIPAA violation. So our trick was to take all the data of Mayo Clinic and its history, 150 years of 10 million patients, and with the unstructured text, do what we call hiding in plain sight. And what that means is instead of saying this informatics leader in Texas, we might just say this educational innovator. Well, educational innovators, there are lots of those. That's pretty de-identified. Job role, geography, familial relationships, all have to be changed in some subtle way so that re-identification is hard. Well, there's another problem, and that is imagine that your de-identified text has dates in it. Now, what if, just to make this up too, some famous person was in an auto accident on in November of 2023 on a specific date? Well, somebody reading the de-identified data could say, well, it says auto accident, that's the date. Oh, maybe it's that person. So we do what's called date shifting, and that is pick a number between 1 and 365. For each patient in your entire medical record store, add that random number to every single date in their record, shifting every date. So the temporal relationship is the same, but every actual date has been changed. So that notion of hiding in plain sight plus date shifting creates a corpus of billions of notes, operative reports, histories, and physicals that could be used for creation of models. Well, and then there's some other modes you might want, not just the unstructured and the structured text, but what about images? CTs, MRIs, PET scans, plain films. Well, there's a problem. Some of you, in looking at old film-based x-rays, may note that the patient card was actually imprinted on the film itself. And so if you've got a name on the film, you better use optical character recognition to search for that and delete it. Or what about a CT or MRI of the head? If you do thin sections, is that going to reveal the identity? Well, use Terra Recon, a 3D reconstruction system, and you can create a three-dimensional representation from CTs of the head and create a face. And that face can be recognized with publicly available internet data about 27% of the time. It's not DID. So you have to do such things as blurring of the skin layer of CT or MRI images, and so on. As you go through every kind of data in your database, figure out what it means to de-identify it. Probably the hardest is the genome, because what is a de-identified genome? I was the second human sequenced in the Human Genome Project, and so my data has been fully public for over 15 years, and that's okay with me. But many people would probably not find the reuse of their full 3 billion base pairs to be acceptable. So you have to ask, can you take pieces of the DNA, biomarkers, subsets that many people might have? So the end result was we had, in 2020, moved 10 million patients, complete records, to a cloud container fully de-identified and ready for AI. We then built an AI factory on top of that DID data so that you could use various tools to create various models. And we made that set of tools available to all of the staff of Mayo Clinic. And a policy was made that as long as you don't try to re-ID and you keep the data inside Mayo's cloud, that you can do research and you can do new product innovation on that DID data. Okay, well, that's great. But a question for you. Mayo is in Minnesota, and we also have sites in Florida and Arizona. If we take the data of Florida, Arizona, and Minnesota and create a model with it, and then use that model in Texas, will it work? Will it be fair, appropriate, valid, equitable, and safe? Maybe not. Could very well be that the demographics of Texas and Minnesota are different. It could be the food we eat, the air we breathe. There could be enough differences to say the algorithm without local tuning could do harm. And so what Mayo had to do was to say Mayo Clinic itself doesn't have enough data. So we have to find other partners around the country. And so we immediately began talking to Mercy, and Mercy brought Arkansas, Oklahoma, and Missouri. We've been to Duke and Vanderbilt and Banner and a number of other health systems working in a similar notion of de-identifying and creating cloud containers of data so that AI models can be developed and validated. And then we started talking to Canada, UHN, University Health Network, Brazil, Albert Einstein, Sheba in Israel, and then started doing country scale discussions with South Korea, Singapore. Last week I was in Denmark, Netherlands, Belgium, and Norway. I tell you all this because, again, a foundation to any model you build must be very large amounts of extraordinarily high quality curated data, de-identified and prepared for model creation. And in this method that I've described to you of create a cloud container, de-identify the information, each entity participating in this federation controls the use and flow of the DID information. And whether you use Amazon or Microsoft or Google Cloud, completely up to you. Great. So now we have the world's data available to us. What kind of models do you create? Well, tonight, we'll be talking about generative AI and large language models, but I also want to talk a little bit about predictive models, just to give you a sense of the sort of things that are possible when you have large data sets. So let me give you some case examples. So I have a supraventricular tachycardia. That means my heart rate, which is normally 50, sometimes goes to 170. Irritating, not life-threatening. And so imagine that algorithms can help diagnose my heart condition and rule out the bad stuff without my ever having to leave my living room. Mayo Clinic, in looking at millions of patients, has developed a whole series of cardiology diagnostic algorithms with very high positive predictive value. So that is, a patient, even with just a lead 1 ECG from their Apple Watch or their AliveCore device, can send that data to a Mayo Clinic algorithm, and we can look at probabilities of heart dysfunction like low ejection fraction, cardiomyopathies, pulmonary hypertension, or valvular disease, and understand, again, mathematically, if that patient is likely to have or develop such conditions. We did that on me, and it said, your heart's completely fine. You just have a conduction problem. I was ultimately given 25 cents a day of a calcium channel blocker, diltiazem, and the end result is I'm cured. And I never had to get expensive testing. I never had to travel. So you can start to see that these algorithms are a nice way of democratizing access to specialty knowledge. And we've done similar things with radiology, neurology, behavioral health. So that's set now about 180 predictive models. Some have gone through FDA clearance, some are pop health, don't require FDA clearance, starts to create a really different kind of way of delivering healthcare, where it can be done safely with great equity around the world by taking the knowledge of the past and helping understand the diagnosis and treatment of patients in the future. So that's predictive. And the nice thing about predictive AI is that we can judge it against ground truth. We can actually see, did the patient develop that disease or not? And then we can decide, did the algorithm provide some benefit or no? Generative AI is an entirely different kind of creature. So I'm sure that as you've used ChatGPT or various other kinds of large language models or generative AI, DALL-E for pictures or Claude from Anthropic, what you recognize is each of these kinds of models is, I mean, in the case of large language models, simply predicting the next word in a sentence. It's not sentient. It doesn't have any sense of accuracy or quality. It's just predicting the next word in a sentence. Now, some of that looks pretty amazing and seems to be pretty coherent. However, a question to ask yourself, although you could give a large language model a question and get an essay, or take a amount, say, text you wrote and say, simplify this text for a sixth grader, summarize this text, and it all seems to work pretty well. Would you use a large language model for diagnosis and treatment of your family? Here's the challenge. As you've probably seen, large language models fabricate or hallucinate. So about 20% of the content is just not factual. And let me give you some examples of that. One of our cardiology experts used a generative AI model to help advise clinical care for a patient as an experiment. Said, this patient just had a sternotomy, and next to that open heart surgery scar, I want to put a pacemaker wire. Is that safe? Well, the generative AI responded, there's been a clinical trial with 5,000 patients. In fact, the entire study is in the Journal of Clinical Electrophysiology, January 2023, page 411. It's just, yes, very safe. The study was never done and the journal doesn't exist. But it does a perfect job in creating a bibliographic form of a journal that you would find in PubMed. It just, in this case, the journal and the article didn't exist. So again, you have to be a little careful about trying to use these things in a clinical context. Another example, for those of you who went to the HLTH, the health conference, on stage, we said to 5 different generative AI products, here's a case, 48-year-old woman, esophageal cancer, it's penetrating the muscularis layer, has 1 positive lymph node, no distal metastases. What is the stage of this cancer? Every one of the generative AI products came up with a different answer. We waited 5 minutes, asked again, and got a completely different answer for each one of the models. So again, good, these things can write text, edit text, summarize. Bad, there's absolutely no guarantee of clinical quality or accuracy or safety. And in fact, they lack transparency, consistency, and reliability. We don't, in fact, really even know how any of them are trained. I mean, yes, certain kinds of disclosures have been made on specialty models like MedPalm from Google, but generally these things are trained on the public internet data, which has all kinds of bias. So the question, I suppose, is if we want to use these generative AI models in the future for something that is going to help us with diagnosis and treatment, not just administrative tasks like composing email or summarizing charts, are there ways we can rethink how we're training these things, and potentially could there be positive clinical use of them. Mayo has 5 different projects in the generative AI space that I'll describe to you to give you a sense of our thinking. As we talked about, large language models are predicting the next word in a sentence. Well, I could argue that medicine is not about predicting the next word in a sentence. Medicine is about predicting the next event in a patient journey. And that event could be take a med, get a lab test, hospitalization, get some exercise, change your lifestyle, right? Could be anything. So what if instead of tokenizing the words in the medical record, we tokenize every event in a patient journey for 100 million people, and then train the model to be not a large language model, but we'll call it a large medical model. And you say, hey, I have a patient in front of me now. These are the signs and symptoms. This is the history. And the large medical model says, oh, you should order these lab tests, consider these diagnoses, consider these medications. That starts to be potentially clinically useful. We don't know if it's going to have the accuracy and the quality that we need, but we are going to do a formal randomized clinical trial, and we'll create the completely novel foundation model from scratch based on patient event prediction and report to you in a couple of quarters if it works or not. Well, other things you could do. Mayo would like to see if we can use a multimodal generative AI model to take X-ray images like chest X-rays, and in fact have the generative AI read the chest X-ray and produce a chest X-ray report, and see if in fact you can create a large language model radiologist and writing completely coherent and we hope clinically accurate and relevant reports. Very difficult to assess the quality and the safety of that. But again, we're going to try to get a sense of, does that approach work or not? We also, because Mayo has 79,000 employees, offered a competition to all the employees of Mayo. We said, we're going to make grant funds available. We want to hear from you. What are the areas you would like to explore in the areas of medicine or surgery, emergency medicine? We got 355 grant proposals. We picked 42, ultimately 6 areas of study. And those 6 areas of study are going to help triage patients on their journeys, are going to help specific specialties with best practices of diagnosis and treatment. Again, we're going to test these things, do it in a research context, see how they work. We also established a sort of skunk works. That skunk works is going to try something kind of interesting. Can a large language model be trained to read the output of other large language models and assess its accuracy and quality? I know, again, that sounds a little bit like a snake eating its own tail, having a large language model read the output of large language models and assess if it's good or bad. And of course, you could probably ask the next obvious question. So what do you do to supervise the editor? Oh, it's another large language model, and so on and so on and so on. But again, we're going to try this, see if it can help with potentially reducing hallucinations and identifying problems of large language model quality. And we will create a large language model from scratch using nothing more than the highly curated, de-identified text data of Mayo Clinic, with the hope that it will have a better, unbiased training set with better accuracy, and hopefully will be, when you use it for things like writing clinical email, writing clinical documents, summarizing charts, that it will have better clinical accuracy. So these are 5 bold experiments, and we're going to see over these next couple of quarters what works and not. because it is truly a very early time in the world of generative AI for healthcare. Regulatory issues are also important to pay attention to. You'll see that 2 Mondays ago, President Biden signed an executive order on AI safety, security, and transparency. That executive order, 111 pages, mentions healthcare 33 times. In it, that executive order says Health and Human Services must, in 180 days, create a public-private partnership that is going to help us with the guardrails and guidance for the use of AI in healthcare. The notion, as I've described, for predictive AI is that you can build a lab and it can test whether or not these things work well or not. So I think you'll see in the next year a nationwide network of AI assurance labs testing and publicly reporting on the fairness and utility of the kind of predicting algorithms that we have today. Where it's going to get harder is regulatory oversight of generative AI, because as we've been talking about, assessing its quality and accuracy is just devilishly difficult. And predictive AI, I can validate an algorithm and then be reasonably assured that it will work in a consistent fashion. But with generative AI, every time you prompt it, you get a different answer. Very hard to test it once. You're going to have to test it almost every time it's used. So I think you're going to see in the short term regulation or policy just say, don't use these things for diagnosis and treatment of patients. Use them for administrative tasks, things that will be burden reduction. And as Mayo and others do experiments, and we have ways of oversight, editing, and checking, potentially then the use can be expanded. But for now, that's kind of where we are with the state of the art with generative AI for healthcare. Policy, as I say, will continue. You're going to see the Office of the National Coordinator, the folks at ONC, likely create a set of regulatory guidance on December 14th and 15th at their annual meeting. And so combination of executive order and this work that's being done by the Office of the National Coordinator, likely to give the country some early government oversight. But there'll be a public-private partnership. The Coalition for Health AI, which I co-chair, will provide a lot of the guidance and the guardrails coming from the private sector, taking the what that has been suggested from government entities and turning it into the how it actually gets created. And so I certainly encourage all of you to go to coalitionforhealthai.org, and you'll find all the resources there for free about how we as a country should begin to measure and monitor the entire life cycle of AI going forward. There'll be a lot more on generative AI coming soon. Well, Anna, I wanted to make sure we had plenty of time for questions and discussion. So let me pause there and open it up to the group, because obviously I get to live this every day and thrilled to answer any questions.
Thank you so much, Dr. Halamka. You have provided such a wonderful overview, and not only of the successes, but the challenges that we have ahead, and also food for thought and inspiration of what is going to come. But also, I think it's most important, I think we talk about the regulatory and the policies that they're coming ahead, because also in order for the public to be engaged and accept this new way to deliver healthcare system, they have to be informed. There's no doubt about it. And so thank you for that. We would like to open the questions to the audience. And please raise your hand, or do we have something in the chat?
Yes, Dr. Cleveland, we do have a question from our chat, and that is coming from James Spence. And his question is, what types of organizations do you see taking the lead in development of medical models as opposed to large language models?
Sure. So you're going to see three different kinds of organizations. We know the big tech organizations are all working on their own healthcare products. And that's great because it takes a huge amount of computing power. GPUs, potentially 50 or $100 million of compute to develop some of these things from scratch. One challenge is those big tech companies, they can develop models based on such things as PubMed, the research literature. They don't have independent access to DID patient data. So I think you're going to see it's a combination of big tech working with provider organizations in an ethical fashion with IRB supervision that will create some of these new models. They'll bring the compute, healthcare organizations will bring DID data, and it will have good governance and oversight. That's sort of one. I certainly see a lot of entrepreneurial organizations, smaller companies working on niche models. And some of these things are, how do I help a doctor in a certain specialty write a note? How do I offer advice to a patient in a language or at an educational level they can understand? How do I create a note so it is ambient listening? Doctor and patient have a conversation, create a note, insert it into the medical record, reduce a lot of burden, and hopefully capture the narrative accurately. So there's lots of creativity there. And certainly, I think you're going to see the research community doing just a lot of investigation into the theoretical ways in which these large language models can offer utility. And by large language, I mean generative AI for your question. So, for example, we have some researchers at Mayo looking at, could these things de-identify records? Right now, you heard me describe how arduous it is to do the hiding in plain sight removal of job, geography, and familial relationship. Maybe a generative AI could do that for us. So big tech working with healthcare and entrepreneurs and the research community will all advance us.
To recognize Dr. Spence. He comes from UTMB Anderson Cancer Center in Houston. So thank you for joining, Dr. Spence.
The next comment question is from Christine. Thank you for your talk. When you think about AI providing insights for care for global populations, how do you incorporate data from other countries and diverse global populations who may need informatics support to make their care information ready for analysis?
Okay, so Anna, this person gets the A+ for the best question of the night.
Okay.
So as you go,
I'm keeping record.
So as you go around the world, what you have to ask is, unfortunately, there is a digital divide where many countries simply aren't recording data in a digital form so it can be analyzed. And what that results in is bias, right? As exactly you point out, if there are whole populations for which no data is available, then how are you going to create a model that is going to help that population? So what we've agreed to do, just to start, is we have done a world survey of every society on this planet that is in some way recording data in a digital form that can be used for training. Some countries in sub-Saharan Africa use a EHR called DHIS2, which is more about an epidemiological population health database than an individual longitudinal record, but it's still data that is suitable for training. So I have teams right now in sub-Saharan Africa looking at data quality, looking at potential. And I'll just tell you the countries we have found so far that have data that is sufficient for training are Nigeria, Ghana, Senegal, Kenya, Rwanda, Uganda, and Ethiopia. And so you've heard me describe, okay, well, I've got, Korea, Singapore, Canada, North America, South America, Israel, Northern Europe. Well, next year, 7 countries in sub-Saharan Africa. Then in Latin America, well, we already have Brazil, but we'll move on to Mexico, Chile, Colombia, Dominican Republic. And then there are a number in Southeast Asia. We are working closely with India. I've done a lot of work in northern India. And there is some curated data in India, but we're also working on Philippines, Bangladesh, Turkey, Qatar, Malaysia, and Thailand. So all told, we think there'll be about 2.9 billion people with digital data sufficient for training. That's a start. And by no means does it address all the equity issues, but it's a lot better than just relying on US data alone.
Next question is from Maddie. I would love to know Dr. Halamka's thoughts on Glass Health AI and if their language model process could impact the work Mayo's doing.
Now, Glass Health AI, I have to tell you, I have not done a deep dive. I mean, I'm familiar with the company. I mean, there's a number of organizations that are trying to create novel large language models from data sets that they are acquiring. But again, I promise the following, Anna. Let me see if I can learn a little bit more about the nature of their training data, and then I will write you an email with an analysis.
Next question is from Bhavana. What do you see in healthcare in the future? Is it going to be replaced with AI, or do we still have challenges in using that in healthcare?
So what a brilliant question that is too. So a couple of weeks ago, the president of the AMA and I gave a keynote, and the president of the AMA said, you know, the American Medical Association, we don't use the term artificial intelligence, we use the term augmented intelligence. Because the reality is, if an AI can replace your doctor, an AI should replace your doctor, right? That is, we go to doctors for empathy, respect, listening, personal journey planning, a whole lot more than just reciting facts from a textbook. So the notion would be, yes, AI can make humans better by analyzing things we can't see or patterns that we can't detect or literature we can't always read. But it's unlikely that AI is going to have that bond, that kind of completeness in creating a doctor-patient relationship. So I would hope that we will have a human working with AI, working with a human. Now, that being said, there must, of course, be exceptions. On my flight recently back from Norway, I sat next to an Antarctic explorer. And this Antarctic explorer said, I work in areas of the world where there are just no doctors. I would actually be fine if I had an AI that was only 75% right, because my alternative is nothing. So sure, you know, democratizing access to knowledge, even if it's imperfect knowledge and it's not empathetic and it isn't respectful, you can understand. But you'd hope in most circumstances, augmented intelligence to human contact.
So I was thinking, I saw that Jinping Chen, Dr. Chen has a question.
Thank you, Dr. Halamka, for the very insightful presentation. So my question is about given the development of AI, especially the generative AI. So what do you see the research opportunities for individual faculty members in health informatics, especially like faculty, in our department, who may have like limited resources, but we do have been working in AI for a while, have the knowledge, but still kind of see whether the research that we are doing is already done by AI or what are we gonna do next? So really appreciate your insights on this. Thank you.
Well, sure. Of course, again, the big topic of discussion, which you heard me reflect on tonight, is how do we assess the quality and the accuracy of these things? And how do we measure an outcome? I mean, so this is sort of interesting when we think of the whole AI life cycle. Well, okay, we've now got an output. what becomes of that output? Did the clinician find it useful? Did the patient outcome change because of it? How do you measure that, and how do you provide feedback and ongoing learning? So there's a whole lot of unknowns in that whole life cycle. Some other unknowns are, what happens if you do additional fine-tuning and pre-training? Does it make the model better or worse? Does a large language model trained in one very narrow area hallucinate less or become an idiot savant? No one knows. Right? So that's why I outlined these 5 research projects that we have of figuring out completely novel foundation models, multimodal analysis that involve images and text, narrow focused LLMs, and then some very speculative things about measuring quality and accuracy, because all of those things are completely unknown at the moment.
Thank you so much.
I know that you put a question in the chat, Dr. Hannigan. Do you want to verbalize it?
Oh, thank you. I heard a lecturer talk more about holding AI systems more accountable, and his suggestion was they could be designed so that you could ask at any point, what's the source of the information that you're providing? And I guess I'm interested, we're all caught up in this excitement about application, but what sort of influence could we have in the actual design of systems?
So again, brilliant question. So I have had discussions with some of the companies, those big tech companies creating the generative AI. I said, shouldn't it be accountable so that you could at any moment say, and so show me the sources that are behind this? And you know the answer that I got? Well, if we disclose the sources behind it, then you'd see the training data that we used. There could be copyright and intellectual property implications. So by very definition, the nature of the products, and this is not all the big tech companies, it's just some of them, is to not disclose the underlying training data that was behind any answer. I have seen some commercial companies, again, want to be careful here that I have no conflicts of interest and I am not endorsing any company or service here, but you're starting to see, as Google works on MedPalm 2, this notion that it was based on the literature, that it can point back to the literature where things came from. And there's a company called Abridge that is working on such things as ambient listening. And if you click on any sentence, it can say, and this is why I said what I said. And a quick example of this, which you folks may find intriguing, my mom had a brain abscess last year, and I used a generative AI ambient listening system to recreate the patient-doctor conversation to see what the chart would look like. And it went something like this, pretending to be my mom here. My husband died 13 years ago, and I live alone. The generative AI wrote, the patient is an 82-year-old widow. Now, the word widow wasn't used in any conversation. It, in effect, inferred, if I can use that term, widow based on the fact of husband died, lives alone. So maybe that's wrong, however, hard to know, but you could click and it would say, oh, I inferred widow because. And that's what companies like Abridge are starting to do.
Thank you very much.
Well, Anna, you know, I do have maybe one quick story for the group because I've got such wonderful informatics students here. And that is, when I was a graduate student at MIT, what I was taught is always build your systems in a modular fashion with what were called abstraction layers. So that rather than building a giant monolithic system of any kind where the technology will advance and render that monolithic system obsolete, if you have it modular with plug and play kinds of abstraction layers, You could take out a module, put in a module, and you'll be staying up to date with the latest technology. And I tell you that because if you look behind me, you could see two clocks. And these two clocks are kind of the exemplar of this principle. The clock that's over here, in 1905, a gentleman in Armonk, New York, said, I bet I can, using modular standard off-the-shelf components, create automations that will reduce human burden. So he took a Singer sewing machine motor, and when the clock weights go halfway down, the Singer sewing machine puts them back up. In effect, since 1905, the clock over there hasn't needed human winding. Modular, replaceable components. He said, I believe we can do this for many other kinds of devices. He called this company the International Time Recording Company, and then decided to expand his modular standards ideas to other kinds of products. And he renamed the company International Business Machines. So this is Thomas J. Watson's prototype for his young company called IBM. The clock over there is entirely hand-built by a silversmith with not modular components. Nothing is replaceable, nothing is maintainable, and absolutely nothing in our modern era can be purchased off the shelf and upgraded. This is Paul Revere's clock. So there you go. I think Thomas J. Watson had something with his modular idea of abstraction layers, and the rest is history.
Well, what a wonderful way to finish your lecture, your presentation today, and a lot of food for thought to see where is the future is going on. And on behalf of the UNT, and of course, the Health Informatics Program, and we have a wonderful also representation here from the Data Science Program and all the programs that we have. Actually, you have a number of guests from many parts of USA. So geographical, we have had a wonderful representation tonight. So from all of us, we want to thank you for your leadership, your hard work, your dedication on behalf of patient care, because ultimately they are the ones that are going to be benefit for all your work and the work of your team. So with that, I want to thank everyone for coming here tonight, sharing for us. And on your own way, I want to thank Dr. Halamka and for your gracious way that you have embraced some of the issues that we have at the start. So with this, I would like to close the lecture for tonight. Thank you very much.